Diagnostic evaluation of syncope has transitioned from a fragmented, test-heavy approach to a standardized, risk-stratified pathway. Current guidelines emphasize that the initial assessment can provide a definitive diagnosis in approximately half of patients. The primary goal of initial evaluation is to differentiate true syncope from mimics like seizures and psychogenic pseudosyncope, and to identify life-threatening cardiac causes. Comprehensive history focus on prodromal symptoms like diaphoresis, nausea, triggers like standing, pain, micturition, and family history of sudden cardiac death. Observation: absence of a prodrome strongly suggests a cardiac arrhythmia or high-grade AV block. Physical examination must include orthostatic blood pressure measurements, supine and 3-minute standing. Orthostatic hypotension is defined as a drop in systolic blood pressure 20 millimeters of mercury or more, or diastolic blood pressure 10 millimeters of mercury or more. 12-lead ECG, although diagnostic in only 5% of cases, it is critical for identifying red flag signs such as bifascicular block, Brugada pattern, long QT, or pre-excitation. Patients are categorized into high, intermediate, or low risk to determine the necessity of hospitalization. High-risk criteria: known structural heart disease, heart failure, syncope during exertion, or abnormal ECG findings. Cardiac biomarkers: high sensitivity troponin, NT-proBNP, and D-dimer are increasingly utilized for triage. Elevated levels are associated with worse outcomes and higher likelihood of a cardiac etiology, particularly in patients with suspected pulmonary embolism or occult myocardial injury. Risk scores: tools like the Canadian Syncope Risk Score help standardize decisions in the emergency department, though clinical judgment remains paramount. When the initial evaluation is inconclusive, further testing is dictated by the suspected mechanism. Carotid sinus massage: patients more than 40 years with unexplained syncope, positive if asystole more than 3 seconds or BP drop more than 50 millimeters of mercury with symptoms. Some have a criteria of asystole more than 6 seconds without symptoms. Head-up tilt test: suspected reflex syncope or delayed orthostasis. Identifies vasovagal, dysautonomic, or psychogenic responses. Prolonged ECG monitoring: suspected intermittent arrhythmia. Implantable loop recorders are superior for rare events with yield up to 35% compared to 24-hour Holter. Echocardiography done when structural heart disease is suspected. Essential if murmurs, history of myocardial infarction, or heart failure are present. Recent research has introduced more precise physiological monitoring and predictive modeling, TCT heart integration. Combining transcranial Doppler with the tilt test allows for the detection of paradoxical cerebral vasoconstriction. Studies indicate that cerebral blood flow velocity can drop 28 seconds before systemic blood pressure falls, identifying a cerebral autoregulation dominant subtype of vasovagal syncope. AI and wearables: artificial intelligence algorithms using smartwatch PPG, that is plethysmogram, photoplethysmogram derived heart rate variability, have shown high accuracy in predicting the onset of vasovagal episodes during orthostatic stress, potentially offering a tool for outpatient monitoring. ICEB marker: the index of cardiac electrophysiology balance, QT by QRS, that can also be indexed as ICEB-C. like QTC, is being investigated as a baseline ECG marker for autonomic dysfunction in patients with recurrent reflex syncope.